T-DM1 is an antibody drug conjugate, which consists of trastuzumab linked to amtansine. Amtansine is a very potent antimicrotubule agent, and so when this antibody drug conjugate binds to HER2, it gets taken in intracellularly, and then the linker releases the amtansine intracellularly, resulting in cell death. So it's a very clever mechanism to deliver very potent chemotherapy into the cancer cell. I think some people like to think of these antibody drug conjugates as smart bombs because they're very targeted delivery of chemotherapy. Given data from Catherine, I do think that any patient who has residual disease after trastuzumab-based chemotherapy should be offered 14 cycles of T-DM1 because, again, it was associated with a 50% reduction in invasive disease-free survival events. And so I do think it also makes us realize the importance of giving therapy in the preoperative setting because it allows us to better understand response to therapy and then tailor adjuvant treatment based on this response. I think prior to Catherine, people weren't uniformly giving patients with locally advanced HER2 positive disease preoperative treatment. We knew data that suggested that preoperative therapy yielded similar outcomes to adjuvant therapy, and so we didn't feel like we had to give the therapy in the preoperative setting. But I think now seeing that we can tailor treatment based on response to preoperative therapy, I think it really should push us to utilize treatment preoperatively, particularly for those patients who have tumors larger than 2 centimeters or who have clinically lymph node positive disease.